I, just wanting to like express like appreciation that this group exists in the first place. I think, it's really exciting to me that, that there's become such like a focus on, technology for development, and even more exciting to me that there's even like a more specific subgroup focusing on like health technologies for development. And so just like to Alan and like this group, just want to extend like, it's really great to know that there's like an active, like different academic communities like this, kind of like, making a lot of headway in the field. And then just also wanted to, extend like a massive thanks to Jordan. She really did like all the work to kind of like bring everyone here together today. So yeah, and Alan, thanks for that introduction, and just kind of like to reintroduce myself. Like I work for Last Mile Health as their digital health lead. Alan mentioned that the WHO has, created its own digital health department to kind of emphasize the importance of how technology is being utilized for healthcare in low and middle income countries. And that kind of thinking and motivation is really aligned with how Last Mile Health perceives like the role of technology in healthcare. And in that same vein, we developed our own digital health department. So that's the department that I lead, based out of our Boston office. But I've also spent about 3 years working for Last Mile Health in Liberia. And before that, worked in the Middle East, Southeast Asia, like mostly in the development field, and specifically in remote healthcare and digital health. So I don't have a presentation for you guys, and generally just kind of wanted to have this be more like a question and answer session, and really just try to kind of understand like what you guys are looking for from, or like what I can help you like better understand about Last Mile Health's work, or your digital health work, or just anything about like the digital health field in general. So kind of how I wanted to structure this was just going to start out by introducing the organization and the work we do. And then maybe do like something of like a shallow dive into our most recent experience in supporting the Ministry of Health in Liberia to deploy a national digital health initiative, and then take some questions and answers around that. And if we have time, like I think wanted to talk a little bit about like what it's like working in the digital health space right now, like specifically as a non-technical person or like a non-programmer, and just kind of like answer any questions you might have around like what it's like either working in the sector or in the field. So to introduce Last Mile Health, we are a community health work organization. We're based in Boston, and our vision is a community health worker for everyone everywhere. And believing in the principles of universal health coverage, we believe the most challenging part of achieving that vision is going to be in the communities that are the most difficult to reach. That's kind of where the last mile comes from, is that we specifically seek out countries and operational contexts that are more challenging than I guess like the norm in LMICs. So we are expanding to a lot of new geographies, and there is a lot of exciting work right now, but most of our experience has been implementing in Liberia, where we've worked for over 10 years. And just kind of want to paint a picture of what that, like what that operational context looks like. So the communities we serve through a Liberia community health worker program often have like very low population density, really large distances between different communities. The road infrastructure is really challenging. Even there's a 6-month-long rainy season that makes it particularly difficult to like travel to different communities to. Whether that's like managing like supervision or like the medical commodity supply chain, just generally like the infrastructure, the road infrastructure introduces like a lot of challenges to delivering health services. specifically for digital health, there's very poor infrastructure around like cellular communication. So a lot of like the typical like mHealth solutions that have been successful in other countries haven't been in Liberia, and we have a lot of like powering and connectivity and communication issues there. So yeah, like I said, we are expanding into like some new geographies, but really want to focus on like what we've done recently in technology in Liberia. So just to kind of set the stage for that, Last Mile Health has we started as a small community health worker program in a rural community called Konabo. And over time, like we began engaging the government around like setting up a national community health system, and particularly in the wake of the Ebola crisis, that there was a lot of enthusiasm as well as funding for health system strengthening. And over time, so we moved into another county called Riversess to essentially map out and essentially pilot a community health worker program that that could be scaled to the entire country, and began as working with several different implementing partners, UNICEF, IRC, Plan International. There's some of the main actors who worked with us in developing a national community health assistant program for Liberia. So that is mostly scaled and does reaches 14 of the 15 counties in Liberia that's supported through the Ministry of Health and through county level governance, alongside like implementing partners whose goal is to be there for a short amount of time to do capacity building and help set up a lot of those systems, and eventually hand off that entire program to the government. And so that kind of sets the stage for a digital health initiative. So that's something that we've been doing since it's a small ODK pilot since early 2015. That is actually something that Alan was able to come into Liberia for a short time to look at that system. And I would say it looked, at the time, it looked like a pretty bread and butter mHealth system, like based off of ODK, doing just like core data collection, a little bit of like clinical decision support, and a little bit of like data reporting at a central level to our M&E team. And I think like engaging the government of Liberia around kind of like their perceptions of that pilot and what they wanted to do in terms of applying technology to healthcare. They wanted to take a much broader approach, and I'm not sure how familiar you are with the WHO's like classification of digital health, but those decision-making components and data collection components are actually like one of many different parts of how they're classifying digital health, and now want to include like electronic supply chain management, e-learning components, telemedicine, alongside like many others. And so we worked with the government of Liberia to start envisioning a digital health initiative that would be rolled out at the national level that would encompass all of these elements over time. And so from, I guess, like kind of like from that ODK pilot, that's sort of like in a lot of ways kind of like it's still being implemented in our operational areas, but in a lot of ways just kind of like put that behind us and kind of like started from scratch with the Ministry of Health, and kind of like we're working together from square one to design a digital health initiative together. And so what we agreed upon was to start with a small e-learning app, call it the continuing clinical education initiative as part of a broader community health academy project that LMH has been working on through the TED Prize. And the idea was through an e-learning app, you can introduce, like if you wanted to introduce like new data collection systems or new supply chain systems, like an e-learning app is a good first step to ensure that you can, have a mechanism to communicate around different and new technologies or different and new policies or parts of a program. It essentially gives you a mechanism to communicate via text and multimedia material and interactive quizzes to basically engage all of these different users and different components of the health system. And that's what we started doing in 2018, is actually just rolling out like a lot of the hardware, like thinking of it as like laying the foundation of a digital health platform as something very, very simple, but allows for new and more sophisticated components, such as like supply chain, M&E components, to kind of be stacked on top of that. And so like the way I kind of look at it is like an operating system. Like you're going to want to install like various apps on that operating system, but what you need first is like a functioning computer that can be used for whatever you want it to. And in this case, it's delivering healthcare. And ultimately, like kind of with that operating system analogy, that also gives like the Ministry of Health, as well as anyone who wants to design a digital health intervention, a much more controlled experience for that community health worker. So a lot of our users are using smartphones for the first time, and there is like it's a somewhat steep learning curve for many of those users in terms of like switching over to that technology. And even things like in our original like pilot testing, just like having ODK installed like on a a normal Android. Yeah. Seeing like some users like accidentally open up the settings menu, not really understanding what's happening with the phone, and just kind of like leave it alone until like a supervisor or somebody can kind of come fix that for them. So both from like a data security standpoint, from like a user experience, both for the patient and for the health worker, like having an environment where the government and different digital health designers could really control the experience of the user, we saw something that was like fundamental to establish in Liberia. So over the last year, we've been implementing or like rolling out those. We have phones, solar panels, and battery packs, so like powering solutions to ensure that the initiative can continue running without an implementing partner providing like regular support within that community. And at this point, we've rolled it out to about 2/3 of the program, and hope to have full programmatic coverage across Liberia by the end of this calendar year. So again, like very simple, like where we are right now is essentially just having mobile phones and a small e-learning app in the field right now. But where we are taking that is working with the ministry to create a consolidated monitoring and evaluation system and a digital supply chain system. And as these new components are added to the program, I think something we've seen across the world is like very heavy fragmentation across different digital health solutions. And so kind of like the end vision for Liberia's digital health initiative is just a very consistent experience for both the users and across the entire system components. So just want to comment on a few things that I think that we're doing differently that's led to a lot of our successes, and then just kind of want to open it up to you guys to ask any questions. So the first one is that we've been more specific in terms of how we define sustainability, or sorry, scalability. In that, like a lot of digital health actors, they approach scalability as you want to create an application or some kind of software solution that can be adopted by your operational areas, and then more and more actors. Like basically an indefinite scale model is kind of like what a lot of people are using right now. But changing that focus to like a national program, we were able to be very specific in terms of like what we define scale as well as like what the maximum number of users are. So right now, it's very hard to imagine there being more than 10,000 community health workers in Liberia just because of the size of that country. And so we didn't need to design a system that could be, indefinitely scaled through, like greater and more sophisticated like systems architecture. We really only needed to come up with a solution that would continue, that would be able to support that workforce. And then I think something else that we've been doing differently is like I've seen like a lot of projects, they design a very strong and a very complex digital health intervention, and it lasts throughout its funding period, and that kind of at the end of that funding period, they hand it over to a government to continue implementing. And pretty quickly after that handover process, like you see, the systems kind of like either like not being adopted or like really struggle to be the same initiative that it was when it was funded or being implemented by a nonprofit partner. And so I think something that we're doing differently is designing, like I said, we kind of like pushed our ODK pilot off to the side and kind of started from scratch with the government. And I do think that's something that has been very effective for Liberia is just making sure that the government is really in the driver's seat, is really making decisions and steering the design of their digital health intervention. And that kind of like government ownership is not something that's kind of like tacked onto the end of a project. And then finally, like thinking of it as an iterative process, like as far as like an initiative or a platform, that it's not creating like a single M&E, like very robust M&E system that's going to last forever and that you implemented. It's technology, it's software it needs to be adaptable. You want to kind of like grow both the government's ability to use and manage that system, as well as you want to grow and manage your end users' ability to increase like the complexity of different workflows that they're going to be using. And that's not really something that you can introduce to either government or users from day one. It is like in terms of like capacity building, just slowly introducing different users and stakeholders to that technology and kind of incubating their ability to use it over time. So I'm going to pause there, and yeah, I'd love to answer any questions you guys have.
So thanks. Let me just take the introduction prerogative to, first of all, that was really a number of lessons that I think resonate with a lot of us who've been working in this space. I mean, engagement of government is absolutely critical. One thing I was wondering about is Murphy's Law. And I know that given the sort of experience you guys have had in a very challenging place like River Cess and rural Liberia, I mean, I've been working in development for several decades, and the challenges under which you guys operate in Liberia were something that was, to me, unprecedented. So I wonder, like, what were some of the lessons that you learned in terms of unexpected developments that emerged as you tried to roll out programs one and then this current program, things that you had failed to anticipate or surprised by once you released the technology in the wild?
Sorry.
So I think maybe like the first one, the one that I was like most surprised by is the impact of multimedia materials. So again, like started out with a pretty standard mHealth application. It really just like very traditional data collection, decision support. That's the core of mHealth, right? And I think what changed is just like no, I think like the community health workers, they just didn't care for it. Like they were willing to do it, but especially at like the level where like when a community health worker is sitting in front of a patient, especially one that doesn't have a lot of confidence in using that technology, doesn't have like the literacy level to kind of read at the speed and convenience as like a lot of us do, it is painful to actually watch like somebody use a clinical decision-making mHealth tool to like actually take care of a patient. It takes a long time. It just like, it's not intuitive. Like the patient has a, brick of technology between them and their caregiver. Like I think that was the most surprising thing that I found is, while there is like a lot of examples of successful clinical decision support tools, I was surprised at how much those tools did not apply to our context. And kind of like the inverse of that was when we introduced just sort of like an assortment of open source videos that were relevant to our program. So around like maternal care, like nutrition, just like fairly generic health videos. And I think where I was surprised was the reaction around that, and kind of like what users wanted was, in kind of like against that controlled experience, they want to be able to use those tools in a way that's intuitive to them, in a way that serves them, or it can be useful for them when like a challenge arises or a situation comes up. And with the videos that we had launched on those phones, we had like reports of community health workers saying like, yeah, there was like a mother who had, told me her child had pneumonia, was like completely convinced that her child had pneumonia. So I turned on, like my cell phone, I showed her a video of like what pneumonia symptoms look like. And the community health worker and the mother like came to the agreement that the child probably did not have pneumonia. I think in terms of like what can be like unexpected or go wrong, like we've also seen like people use like those like health videos for like community entertainment. Like I've also seen like we've put up a lot of like we have like a kiosk software again, like an operating system, trying to create a very controlled experience. And it's been fun and challenging to watch people try and break that system, to try and use that phone for personal uses. And I think once they do unlock it, that's really when like anything and everything can come onto that phone. But yeah, that's I think like really like the most like powerful thing to me was like around, I think like what I had originally thought was just like this kind of like text-based decision support. These are like very rigid tools that should guide or kind of shepherd a community health worker to the right outcome. Where I think is what like the users were actually demanding were just like tools that they could actually use kind of at their discretion, or just something that gave them the flexibility and really like the control to apply that technology when they needed it.
I have a pretty general question. So for a lot of us, we don't have computer science background and we don't have a very advanced programming skills. So how would you suggest us to enter the field of digital health, and what kind of competencies or skills do you think is most important?
Yeah. So I actually wrote a few down on that. So I also am not a programmer, and generally like not that technical of a person. And so I think maybe like so I think like the field is like it's expanding, and I think like a lot of like like the traditional roles that we see in like app development or computer science related fields, like a lot of like particularly a lot of like those business systems are beginning to emerge in like the nonprofit sector. There's like I don't have a lot of experience in that field, but there's also like an enormous emerging like social enterprise, that I think like similarly like jobs are coming up there. So I'd say like the first recommendation is a gentleman named Wei Fota has the ICT Works group, and they're really great about like especially for like international postings. Like they do specifically focus on like technology professionals or like digital health professionals that and highlighting opportunities there. But in terms of like what I would focus on is I think like and I'm gonna like think more about like the nonprofit sector just because that's the one that I'm familiar with. And there I think like the first thing to recognize is like these are not rich organizations, and like a lot of people are kind of like wondering like like where their next meal is coming from, and making sure that they can sustain and protect their business. And I think just like in a resource constrained environment, that's always like one of the primary considerations for an organization. So I think, and I think that's how like many staff for candidates are evaluated in terms of like how they can contribute in some way to, if you think about it as revenue, how they staff can increase like that revenue stream to an organization. And so just generally saying like in terms of like grant compliance and like project management, and particularly like fundraising and networking, ensuring that like those that those skills are there, or at least that you can effectively communicate what your skills in those areas are, is something that's going to be very, very compelling to people who are hiring outside of I guess like traditional software engineers. In that same vein, as we said, like increasingly governments are having a greater role in digital technologies, or digital technologies in general, and even like within like the private sector, like with like the Uganda mHealth moratorium is like an example of just like, even if it's not a government implemented program, there is still a lot of like politics and a lot of policy coming around digital health implementation. So I think that's a skill set that I think a lot of like mHealth or digital health professionals don't have, is that policy and government engagement, just like particularly like being able to interact with like ministries of health and LMICs, like that is, I think that's something of a rare skill to have, and generally just being aware of like the different bureaucracies and policies that exist. And then fundamentally, I think like when you do see like a lot of like these technology systems that are emerging, like a lot of them are actually like very, very basic, like just very, very rudimentary data collection, and there's actually not a lot of like software engineering support that's needed on for these projects. But at the same time, like these projects, the scopes of work are going to have like, we're going to like integrate with like a complex backend system, or like we're going to like do something that on like surface level seems very, very technical, very, very software intensive. But fundamentally, like most of those actors just want a functioning system that everybody can use, that pulls data into a single place. And so I do think like fundamentally what people are looking for are systems builders, and people like, there might be a software engineering component, but that's very easy to kind of like pull that talent in. So making sure that like really approaching things as more of like a project manager, or really more as a systems builder, I think it is, and finding a way to communicate that to like different employers is going to be a really important aspect. And then one last thought is, think about becoming like a programmer. Like it's really like, even just like at an amateur level, like it is actually like a even if you only have like a surface kind of like understanding of software development, like that goes a really long way in terms of like that project management, are really kind of like cutting through what all like this like technical jargon, often coming from like fundraisers and government people, not from engineers. Is like just kind of having like some kind of like technical edge. It does really help, and I don't think that means like pivoting over to become an engineer, but just like getting some of that background is actually like I think really advantageous.
Yeah, I have a question in regards to, you brought it up a little bit with low digital literacy among community health workers, like go all the way up to officers in the Ministry of Health. And there's going to be hundreds, possibly thousands of smart devices throughout these communities. And you also have donors who want organizations to be answerable to the security and use of the devices. So what's your opinion on having kind of mobile device management applications on these phones and limiting the capabilities of them in regards to like how much data they're using, locking down settings like you said earlier, limiting applications, things like that, or allowing them just to have open access to the phone and that they might use more.
Yeah. So I guess I'll kind of like separate that and first talk about like mobile enterprise management. And we've kind of hacked our way through it. Like we have a, you know, like custom kiosk software that locks down like the actual like Android phone that allows us really to control like which apps are installed and which apps can be accessed on the phone. So that kind of like user restriction really just focuses on like which apps can be accessed and doesn't do like a lot in terms of like inventory management. It does nothing in terms of like inventory management or like controlling like how much data is used. I've seen a really intriguing solution. I think it's coming out of Dimagi, and they just rebranded to Focus. And I believe before they were called Mobile at Work. Bringing together like some really cool like mobile management enterprise solutions to the field, and just generally, I feel like that's often not a consideration around like designing digital health initiatives. It's like, how are we actually like going to manage this intervention? Like most of the effort is this, I feel like, put into like around like the data system and kind of like what data it collects and kind of like, you know, like a lot of like system architecture diagrams, but never really focusing on like the operational and logistical components of digital health. And I think, kind of back to your point, I think that's like when I'm thinking about like systems building, that I think those kind of like operational elements are going to become increasingly important. And then the second part of the question was, sorry.
I mean, just your opinion on like the necessity of it, and if community health workers will be more apt to actually use the phone if it's not as locked down as if you were to have that mobile device management.
Right, and that I kind of see it as like two fundamentally different like schools of thought, like a bring your own phone model versus kind of like one that we have like a very like tightly controlled experience. And I think ultimately they have kind of like different use cases, and so I don't want to be like prescriptive in saying like, you know, like this solution, you know, it's working really well for us, like, you know, like lock down those phones. I think like a good example of like how a bring your own phone model might work is at like a client level intervention, right? Like if you have like a, you know, an app that helps an individual like diagnose themselves, right? You don't need to create a controlled experience. You just want to create one of many different apps that might sit on that phone. Maybe another example of where that could work is in a less formal like community health volunteer program where you don't want to like equip them, or like you don't have the funds or whatever to give them all of this equipment, but you still want to encourage them to use, you know, elements of technology in their work. I think that's another really great opportunity for that kind of bring your own phone model. For community health worker programs or health work programs in general, I do feel like the trend is going towards you know, more lockdown devices. And I just think of like when I go to like a hospital here, there's like a dedicated kiosk of some kind that's like restricted for those like health professionals to use it for treatment purposes. And especially like with that technology, as like it's a big deal, right? Like if you introduce like a smartphone into, you know, like every rural community in Liberia, and a lot of them haven't seen a smartphone, like that is like, it's just so much more than a health device, right? And so I think there's a huge role in that kind of like enterprise management like software or like solutions to ensure that, you know, like that equipment that you're rolling out is used for its specified purposes. I
mean, it's a really fascinating question because it really, I mean, we've struggled with CHW programs in a number of other South Asian countries, and that's been one of the foundational debates of whether you unlock the device and provide access to other apps as sort of a reward for performance. But there's two things which sort of, I think, tip the scales towards us also locking down, hundreds of phones that are out there. Three things. One is the longevity of the device, right? Because you have a purpose for the device to either capture data or provide decision support or some other part of that workflow. If that device is compromised, then that workflow is impaired. The second part is costs are linear, right? So SMSs, data packages, you can negotiate some bulk discounts, but at the end of the day, the more data you use, the more expensive it's going to be. And so initially we found data just running out of our workforce's packages. And I won't even mention in this audience, like the kinds of things that were being browsed were things that as a public health organization, we weren't very proud of to show in our sort of browser history, but that, as you said, when you open up information, there'll be good access and bad access, right? And so that was also problematic. And I think, lastly, I think this idea of seriousness, right? You see this as a professional work tool. And in countries where there's a strong gender disparity, we found that the moment a smartphone entered the household, our enterprise manager software was sending out ping alerts that SIM removed, right? So the husbands were confiscating the phone and putting in their own SIM to try and use it for their own purposes. And when they would get a call saying, this is an official phone, please return the original SIM, like, oops, here, take it back. And so it gave control of the device back to the worker.
And if I can just add a fourth one to that is data security. And these are devices that are being used to collect data on sensitive information. And I think it's not really an area where like a lot of people are. There is a lot of thought being put into it, but generally that's data security or patient privacy is not a big emphasis in the industry. And when you said like a lot of things you're not proud of in that browser history, like a lot of malicious software as well. Like and just that's something like that information is just something that needs, and the security of that information is something that needs to be like tightly controlled.
I had a question, kind of going off of what you were saying about these social dynamics that are happening when you're introducing cell phones into, especially these last mile, really rural settings. So I'm actually working on a CHW mHealth program that's in a last mile setting, and no one has really had an Android before. It's in Uganda, so there's a lot of complicated digital technology issues there. And what seems to be happening is that like when you're giving, say 10 people in an entire village an Android, all of a sudden those people become the most important people, and they're seen as like a little bit more powerful. It just kind of like shifts dynamics. And then that person's also now the person that's asking you about really personal information, or like HIV status and stuff like that. So I was wondering if that's something that you guys at LMH have seen, or something that you consider addressing, or that's an issue.
Yeah, I think that's not like that's not really like a dynamic that anybody has like specifically told me about, but that might be more of like an observable that dynamic with the community. I guess like what I've seen more is like the status of being a community health worker is bigger than the status of I'm a mobile phone owner. And like I think even if there's not high mobile penetration in communities, there's high mobile penetration in the world. And now like you see phones on TV, you see, like you go into like a more urban area, you see like a lot of cell phones. So I don't think, like in comparison, like I can think of like projects like in India where it was very much like that. You give, this is like back in like 2012, kind of like when sort of like smartphones were just kind of like the cost or like price point on them was kind of like becoming more affordable, and it still was like a very big deal to have a smartphone. And so I can recall like examples from that where it was like it was like a very big deal to that community for somebody to be equipped with a smartphone. But now, like, yeah, I really struggle to think of like any like anecdotes of somebody just being like, like, yeah, this is giving me like increased status in my community. I think rather what I hear is like through this device, like I I'm learning something, I'm learning computers, or like it's increasing like my skill level. Like I think like community health workers seem like very, very proud of having that device and kind of like what it means and sort of like opening doors for their future. But I've heard very little like comments around like, yeah, the community really looks up to me now that I have like a smartphone. Because like normally what I hear is like, now I have two phones, this is great. Like I have a personal phone and a work phone. Yeah. Yeah.
So, I'm just a little curious. You mentioned before that some of the barriers that mental health faces is that there's lack of infrastructure, communication, and telecommunication infrastructure. In my experience, in LMIC is that I have a smartphone, right? But then buying data is very, very expensive. And I noticed the trend that in lower income countries, accessing internet is very much a luxury. Like you buy data per megabyte or per gigabyte. You don't buy them as a monthly unlimited package. It's very, very rare that I see those kind of packages in as an affordable thing to have even for an American traveler to the lower country. So I was wondering how do you balance that? How do you overcome that barrier?
Yeah, so maybe like let me kind of like delve into kind of like some of those barriers within the Liberia context, and then I'll talk a little bit about how we just kind of like sidestep that question entirely. So I think like you're right to say like very, very expensive. Both like the community health assistant can't afford it. I think like in Liberia we have about 4,000 community health assistants right now. Like a monthly, like the low end monthly data package would be like $5 for like a month of data, and so that adds about like $250,000 to the program on an annual basis, right? So like to me, I think like that's like fundamentally a problem like that. That's unaffordable. On top of that, like the internet, like in urban areas, like you do have like 3G networks, but the second that you leave, like the internet speeds are just so abysmal that you just like, you're technically accessing the internet, but it just like, it makes things like transferring multimedia content, particularly like video, it's just like out of the question, even if you could afford those different data packages. And so how we've kind of like, at least in Liberia, how we've sidestepped that question was by creating like offline transfer mechanisms between two devices over Bluetooth and Wi-Fi direct. So we did that for like specifically with like two applications. We first modified OBK Collect to be able to like transfer like new form packages from one user to another, as well as transfer like collected data from one user to another. So like all based around the concept of like a physical supervision structure where, you know, the supervisor would go into the community to collect that data from a user. That could also happen in an inverted way where like a community health worker went to the facility and transferred the data there. But I think like a lot, you know, like I think there's still like a lot, like paper-based M&E systems, like they work and they work more reliably than digital ones. And I think like mimicking a lot of those workflows has been something that has been really advantageous for us. Like, and I think like the disadvantage of that is like obviously like the delay in the amount of time that you need to collect that data. And I think like another risk is like if that supervision isn't working, then you're not getting that data. And I think like around like comments around like, okay, like that, like not having like real-time monitoring systems, I don't know, like that's not really something that like LMH has ever used. Like we don't have like a data person like kind of like sitting with like a feed of like patient information coming in and making decisions off of that. That's something that like is normally like discussed on a monthly basis or a quarterly basis. And so in terms of like evaluating like the cost of that data package, which as you said is like very, very expensive, like what is the value out of that, those real-time monitoring systems? And if you are, you know, like footing the bill for that data, like you really should be getting a lot for something that's that expensive. The other app that we've done this is with Appia Mobile, which is the e-learning app that we're using. We developed like a very similar over Bluetooth to actually move like multimedia content from one device over to another during actual supervision. And again, this is like a way for us to sidestep. Like we don't have if we did want to transfer let's say like an hour worth of like clinical education videos, that we'll probably need to spend more than $5 on an internet package. And again, like in a lot of those remote areas, even the ones that do have cellular access, like the bandwidth speeds just can't support that. So again, kind of like sidestepping that by allowing people to transfer that information over Bluetooth. Sorry, I think you had a question
here.
Sure. It's a very interesting talk. So I am an engineer, and what I'm interested in is the cultural aspects of the app, of apps in general. So I'll just quickly mention the project I'm working on. So it's
24.
Native Americans, Apache, and Sioux Indians. And what we're doing is we're taking a standard app. It's called My Plan. It's developed by Nancy Glass here in school. And trying to translate it to
8.58.
context of each tribe. So we're talking tribes. We're doing things like we're getting engaged with the youth to draw avatars. We have chat bots, like we wanted, bringing the elders. So those are things to make that more.
1, 2, 3, 4.
I'm just wondering if you have someone who is going to design an app for you in your context, what other features you would like?
8.5.
Oh, there's a lot of features like that. And I think you kind of touched on them. I think something that's like increasingly hard to measure is how much fun you're having when you're using an app. Like how much do you enjoy that experience? Like how can you let that experience feel less and less like work and just something that you might do or maybe even enjoy? And I do, I think whether you want to call that like gamification elements or user engagement elements, I do think that is really like the area that a lot of these like mHealth applications or general like ICT4D applications, like some of them are really bad and really really just like unintuitive, just like a really old school kind of user interface. And I do think like bringing, like a lot of like just sort of like the features that, I think we've become like very, very used to. I just think of like Uber as an app and just like all the little animations, all the things that, making it engaging and very intuitive and very simple to use, and then compare that to like a lot of like the traditional mHealth tools. And I mean, they're just like, they're complete, like one, looks like an app that was designed in like the early 2000s, and one looks like one from 2019. And so I do, like the feature that I want is just like more modern tools and kind of like, which again, like within a resource constrained setting, I think that's a really hard decision or trade-off to make, is like how do you make that decision between like creating a really slick UI and versus like extending that initiative maybe to like 200 more people. Like again, like understanding that there's like different trade-offs, but if we're fantasizing about different app features, I think just like generally modernizing them would be, and making them more intuitive and more enjoyable to use would be like the biggest thing I think we can do in terms of like getting more people to use applications.
We had 2 doctoral students this year do their PhDs on digital engagement, really sort of looking at what the gamification world has learned about drawing people to apps and getting them to sort of be sticky and what's the word, delightful. I think that's like the 10th missing principle in this principle, is like be delightful. And I think that's what Apple has figured out. And I think it's something for those of us working in public health, we have to think, is our IMCI decision chart delightful to use or not? And if it's not, then it should be a no-brainer. But like, there's a great example in India, the community health worker tablets that were being developed by the National Public Health Institute included a weather app, like built into their surveillance browser. So, because the community health workers would open it up and say, oh, I need to take an umbrella today, right? It was completely extraneous to the function of the register, but it was a delightful feature that they were like, oh, I want to see what the weather's like, and that would give them some insight into their day.
Maybe just like in a similar vein,
Sure.
like our delightful feature is a flashlight. Like that's really, you talk to people like, I love the flashlight app, like clinical decision support, I could take it or leave it, but I love that flashlight. I think it kind of depends on like what space you think Last Mile Health sits in. I'd say like if you like, I would actually say like we're not a leader in the digital health space. Like I think we're doing a lot of innovative applications of like existing technology, but like we don't like we don't have any like Android software developers. Like we're not an app builder. We're a healthcare organization, and we want to have the best community health workers. And I think to improve that quality of work, like that is really the function that we see for our technology, is it supports community health workers. So as an example, like even with like electronic data collection and reporting, like that's fundamentally a monitoring and evaluation system or a function, like it's a programmatic component. And so the idea isn't to say, well, now we're using technology for this, it's now an IT intervention. It's still an intervention for data managers and data users, and it's being augmented through technology. So I think like the answer to that question is like we're not really in that space. We're kind of like beneficiaries from that space. And
I mean, the Digital Health Atlas is a good place to go to see up-to-date like libraries of things that are being done in this area. And there's USAID has made a bunch of compendia over the years. I think they all give you a sense of what can be done with technology. But I think that's a really, really great sort of note to end on. And one, like the mantra that we always like to put up front is, we are public health professionals leveraging technology where it's appropriate to solve problems, and not technology companies looking to apply technology to any problem that presents itself. So I think there's a really important nuance, and I think you framed it really beautifully. Let's give a round of applause and thanks to you. I just wanted to say it's really great to see so many new faces showing up right now. We're going to try to